Hello and welcome everyone. Today we have a special episode and a collaboration. It is actually our first video podcast between the IVPN Cosmoderm and IVPN Internal Medicine. I would like to welcome our speakers today. It will be a great event. Stick with us. We will be discussing one of the most important and preventable complications of diabetes, which is diabetic foot infection. Every year, thousands of patients are hospitalized and many undergo amputation because of foot ulcers that started as something as simple as a small blister or a crack in the skin. As pharmacists, we're often the last healthcare professionals a patient sees before seeking a medical care. Quick conversation or a simple foot inspection can literally save a limb. Today, I have amazing pharmacist with me, well experienced in the world of pharmacy. I have Dr. Zainab Roumieh. She is a faculty instructor at LAU School of Pharmacy. She's also the lead of IVPN Cosmoderm. She holds a postgrad degree in cosmetic science from the Center of European Masters Program. I also have Dr. Maha Fansa. I'm pleased to announce her as my co-leader for IVPN Internal Medicine. She's a clinical pharmacist, clinical pharmacotherapy specialist in internal medicine. The goal today is to discuss why diabetic foot infection happen. We're going to be discussing the basic dermatology and skincare, how pharmacists can perform simple foot exam, wound cleaning and topical treatments, antibiotic stewardships, and some immediate referrals, red flags. Without any further ado, I would like to welcome our speakers. Welcome, Dr. Zainab, and welcome, Dr. Maha.
For the introduction.
You're very welcome. I'm so happy that we are both here together, and we're just going to start our discussion, and we'll take it from there. What is diabetic foot infection?
Okay. Today's topic is a very interesting topic since we can collaborate between internal medicine and Cosmoderm. So to start with, as a definition of diabetes, and before discussing diabetic foot infections, it's very important to understand diabetes itself. Diabetes is a chronic condition in which the body either doesn't produce enough insulin or cannot use it effectively. So this will lead to elevated blood glucose levels over time. And high blood sugar doesn't only affect the glucose metabolism, it also damages blood vessels, impairs the circulation, weakens the immune response, and can cause nerve damage known as diabetic neuropathy. Neuropathy is one of the main reasons diabetic foot complications occur. Patients may not feel pain from any blister, a cut, a small injury, or pressure injury, and because the injury goes unnoticed, we can see it getting worse and worse and eventually becoming infected. Now, I'll just discuss briefly the risk factors for diabetic foot infections, which include poor glycemic control, long-standing diabetes, peripheral neuropathy, peripheral arterial disease, previous foot ulcers, amputations, foot deformities, smoking, chronic kidney disease, and also improper footwear causing friction and pressure. So this is basically diabetes and diabetic foot infection, and these are the risk factors that we need to look for whenever we have a patient with diabetes.
If you have a patient with diabetes that comes to your pharmacy, what should we be looking for?
So basically, as a dermatology-focused pharmacist, we usually often have an ideal position because we identify early warning signs before the serious complications happen. We have to look for dry skin and excessive scaling, cracked heels and fissures, redness, inflammation, swelling, blisters, changes, any small change in the color of the skin, we need to look for that because this might lead to something more serious. And increased warmth compared with the other foot, drainage or exudate, unpleasant odor, open wounds or ulcerations. So we should also evaluate the nails for any fungal infection, thickened nails, ingrown. From a dermatology perspective, maintaining the skin barrier is extremely important because diabetes often causes xerosis, which is excessive dryness. And when the skin barrier becomes damaged and cracks develop, bacteria can penetrate more easily and we have an increased risk of infection. Can just go ahead and explain it from the hospital perspective.
So I can start basically with the pathophysiology of diabetic foot infection. So typically, as you mentioned, it happens in patients that have diabetes, and the infection is going to happen in the foot. So the pathophysiology focuses on three major factors. The number one is the hyperglycemia state. So those diabetic patients have a high blood glucose level, and having a blood glucose level will impair the immune function, which means that our body won't be able to fight any infection, which will put us at a high risk of infection. Number two is the poor circulation. So those diabetic patients, they don't have a good blood flow in their extremities, such as their fingers or their toes, which means that less blood will reach the foot, less oxygen and less nutrient. So if someone has a wound in the foot, since those patients have a poor circulation, we're going to have a delay wound healing. So if you're going to have a delay wound healing, more bacteria will stay in the wound, and this will affect and exacerbate the diabetic foot infection itself. Then lastly, we have the peripheral neuropathy, as Dr. Zainab mentioned. So those diabetic patients will lose their protective sensation and may not feel if they have any cuts, burns, or blister, or even pressure injuries. So let's say a diabetic patient have a blister on his toes, he's not going to feel it. So he's not going to take care of that blister, and that blister is going to exacerbate over the period of time, and that can be infected and lead to a diabetic foot infection.
It's definitely very concerning. What's scary is that patients don't necessarily feel ulcers or feel the crack, that it's getting worse because of the loss of sensation. And I believe the pharmacist can simply do a foot exam, maybe to help with that, or maybe assess the patient.
So usually for the diagnosis, in the hospital setting, we usually divide the diabetic foot infection into 4 classes. It can be uninfected, where there are no local signs and symptoms of infection. Mild, it is usually defined if there is an erythema less than 2 centimeters, and this can be easily seen on the foot. Moderate, whenever the erythema is more than 2 centimeters. And whenever it's severe, the patient have tachycardia, tachypnea, increase in white blood cells, and fever. And also in the hospital setting, we look at labs such as white blood cells, neutrophils. Those are typically elevated. Same for the ESR and CRP as well. Those are typically elevated in a diabetic foot infection. We can also do some imaging. We typically start by doing an X-ray. And if you want to be more specific, we can do MRI, which is the gold standard imaging for a diabetic foot infection.
Awesome. And from dermatology standpoint, what should we be looking for?
So as I said previously, whenever we have a patient coming to the pharmacy and we have to inspect their feet, and I have to look at both feet at the same time, because as I said, sometimes we have a slight difference, maybe a little bit more warmth or slightly inflamed. So this might tell me that there's something going on with this feet. And also I need to look for redness, any swelling, any drainage, exudate, any foul smell or something. So these are mainly the things. And usually whenever I have a patient coming to the pharmacy, and I know that the patient is taking any antifungal cream or something, I should ask them a question: why are you taking this cream? Because sometimes patients, they just come and grab the cream and leave without even discussing with us why they need that cream or that medication.
It's time to talk about treatments.
I can start talking about wound cleansing first, just briefly, and then we move to the treatment. Wound cleansing is one of the most important factors. And the first principle is to clean the wound gently while avoiding damage to healthy skin tissues, because we still have some healthy skin around the injury and we don't want to damage this. And as I said previously, these patients are immunocompromised, kind of. So that's why this skin is very sensitive, and with harsh chemicals or with harsh cleansing, I can even damage this healthy skin. So the process generally involves, first, we need to thoroughly wash our hands and use clean gloves, of course, and then gently irrigate the wound with saline. Saline is enough, more than enough, to clean the wound. And then we inspect the wound carefully for any redness, swelling, drainage, all these things that we already discussed before. And the surrounding of the skin should be gently dried, and we avoid aggressive rubbing of the wound bed itself. Then an appropriate dressing should be applied based on wound characteristics. The goal is to maintain a moist, healing environment while managing excessive exudate. And there's a very, very common misconception is the use of hydrogen peroxide and alcohol. And however, these can damage healthy tissue and delay wound healing. And that's why the routine use is generally not recommended unless these are specified any healthcare provider. So patients usually should avoid prolonged food soaking because excessive moisture can also weaken the surrounding of the skin and increase the risk of the skin breakdown and worsens the infection. Now I'll move to the treatment as from cosmetics perspective. In the cosmetic, I would like to divide the treatment into four parts. We have the hydration, we have the barrier repair, the infection management, and the scar prevention. If I want to start with the hydration for daily prevention and skin barrier support, we have multiple ingredients. We have urea, but urea, we have different percentages. When we use it at low percentage, 5 to 10% usually, for hydration and dry skin prevention. When I use it for moderate 20 to 25% concentration, this is for rough skin and calluses. Up to 40%, this would be for severe hyperkeratosis and thick cracked heels. But I need to make sure that I don't have any open wound when I use the 40% of urea. I have glycerin to attract and retain moisture, ceramides to restore the barrier function, hyaluronic acid for hydration as well, and panthenol to support the skin repair and soothe irritation. So patients should really moisturize their feet daily, but avoid applying thick creams between the toes, because when we apply thick creams between the toes, this will lead to fungal infection and fungal growth. Now about antibiotics, topical antibiotics. Topical antibiotics, they don't really have a big role in diabetic foot infections. Injuries are infected, so not every time we will need antibiotics. And most commonly, whenever I have an infection, this will need intravenous antibiotics. However, if I need topical antibiotics, we have options such as mupirocin 2% ointment and fusidic acid 2% cream or ointment. And I need to be very careful whenever I use antibiotics because it's very underestimated that even it's topical antibiotic, the risk of resistance is still there. So this is something very important, and they can even cause allergic contact dermatitis when overused. Now for wound healing support, we have hyaluronic acid containing wound products, collagen dressing, medical grade honey preparations, and many more. When we discuss scars, prevention is always better than treatment. So we have to do early wound management, infection control, good glycemic control, maintaining optimal healing environment, protecting the area from repeated trauma. Once it's fully closed, I can manage the scar by using silicone gel sheets or silicone scar gels, and these can be used for at least 2 to 3 months. And we have other ingredients such as allantoin, panthenol, centella asiatica extracts, and others.
So when it comes to the hospital setting, we usually look at the diabetic foot infection based on the classification by the IDSA guideline. So the first classification is uninfected. And I really want to highlight that not all foot ulcers are active. Some of them, we don't really need to treat them. So if the ulcer, based on the clinical scenario, based on the labs, based on the imaging, that is not infected, we do not need to treat with oral or IV antibiotic. And this is something that is very important. The second class is the mild infection. So usually for mild infection, the most common bugs that we encounter is MSSA, which stands for methicillin sensitive Staphylococcus aureus, or streptococci. And for mild infection, we typically use oral agent such as cephalexin, augmentin, or clindamycin if someone cannot tolerate the cephalosporin or penicillin. And then we move to moderate infection, and this is also the most common bugs are MSSA, streptococcus, and also we can have some gram-negative like E. coli, Klebsiella, and some anaerobes as well. So for that, we typically use IV medication, and these are the most common patients that you're going to see in the hospital, patients that have moderate diabetic foot infection where we use IV antibiotic. So the most common one is we can use ceftriaxone with metronidazole to cover anaerobes with the metronidazole, and also we can use ampicillin sulbactam. And then for the last class, which is severe, and the most common bugs are polymicrobial. We can see gram-positive, gram-negative, and anaerobes. And for that, we also use IV antibiotic. The most common one that we encounter are tazobactam, piperacillin tazobactam. We can use meropenem, imipenem with the cilastatin as well. We need to take into consideration if someone has a risk factor for MRSA. So if we live in an area with a high local prevalence of MRSA, severe infection, previous MRSA infection, we need to use a MRSA agent such as vancomycin IV. That's it for the IV medication or PO when it comes to the hospital setting.
When they start receiving IV antibiotics, they usually receive it for a longer period of time, right?
Yeah, we usually target less than 2 weeks when it comes to diabetic foot infection.
But usually we're trying to save the patient limb amputation. As pharmacists, what can we do to help patients preventing progression of the ulcers or the disease? What is our role?
We play a much larger role than many people realize. And first, we contribute to prevention through patient education because we are literally the direct contact and the easiest contact with the patients. All patients pass by pharmacies. So we contribute to also teach patients how to inspect their feet daily, to maintain skin hydration, select appropriate footwear, and recognize early warning signs. We also support medication management and teaching them how to have a good glycemic control, how to test their blood glucose level frequently at home, and also we help in optimizing antibiotic therapy.
Yes.
Add for diabetic patient, like we always tell them to check their blood glucose in the morning, and I would really highlight that they need to inspect their feet on a daily basis as well. Also, they can promote proper footwear.
What Dr. Zainab mentioned too, like you have patients come to your pharmacy, they're trying to buy products, and you can simply ask them like, what do you need this for? And if they're would you mind taking off your shoes? Can I see what you're trying to treat? These simple questions can sometimes really prevent hospitalization and even amputation. Takeaway points for our pharmacists listening to us.
I can start by saying that not every diabetic foot ulcer requires antibiotic. So half of the diabetic foot ulcer are not infected. So antibiotics should only be started when there are signs of infection. Another one is that the severity of the infection determines the empiric antibiotic and not the size. Even though if we have a large ulcer, this does not mean that the patient needs to be admitted and needs to start IV antibiotic. So the empiric antibiotic and not the size itself.
I would like to add some more key points, such as, for example, prevention is better than treatment always. And that's why daily foot inspection and proper skin care can prevent many diabetic foot complications. And it's very important to know that dry skin is not just a cosmetic concern because cracks and fissures can become entry points for infection. Not everyone needs a topical antibiotics. And at the end of this, I would like to say that pharmacists play a critical role in patient education, skin barrier maintenance, wound care counseling, antibiotic stewardship, and early referral.
Early recognition, proper wound care, patient education, and responsible antibiotic use can save limbs and save lives. I would like to thank you both for joining me today. This was very important for me to listen to and very refreshing. I'm sure many other pharmacists listening to us. And remember that sometimes the most valuable clinical intervention starts with asking a patient to take off their shoes. Have a wonderful day.
Thank you.
Thank you.